assessing bioavailability. Press.
Yes.
Do me a favor. I mean, as best you can. Try to, because I know these are your peers, but try to express to, I do anyway, but as a peer, try to express to your classmates how important it is to be in class. Not just this class, but I'm saying in general.
I think that what it was is that since all of the other professors agreed to cancel class, that they were probably expecting for someone to be able to contact you. I think you were emailed and your whatever number is available for you was called.
Why was class canceled?
Because we have a hands-on simulation center with our integrated lab today, and it's like 4 to 5 hours long, all day. So either they pre-recorded and posted it for us to watch it on Blackboard, or only one professor just said she'll have an extended class period that'll run into our lunch break to make up for today, because pretty much that would mean from 8 o'clock in the morning until about 4:35, we had no break. If we had all of these classes. So I'm sure that no, it's not like they just decided I'm not going to come.
All right, that's a little bit better explanation.
Yeah, that's really what happened. It's not like they just don't want to be here.
Oh, okay. Yeah, but I'm saying, what's different about this rock? Okay, so the last method that I want to briefly talk about is this idea of looking at clinical outcomes as a means of assessing bioavailability. In your textbook, I think it's called therapeutic outcomes or something like that. What chapter is this in? 14? 16.
I think you said it was called clinical endpoint study.
Clinical endpoint study, okay. Yeah, it's listed in your textbook though, so it goes by various names. Clinical outcome or clinical endpoint study or whatever is listed in the textbook. So I don't want to trick you up on the name or whatever. One thing I want you to recognize though is that whereas this acute pharmacological effect, remember we said we're looking at something that happens fairly quickly after the administration of the drug, maybe change in heart rate or blood pressure, or we talk about pupil dilation, acute pharmacological effect. Well, those therapeutic endpoints or clinical endpoint studies, okay, is going to be a study that's actually designed to look at the therapeutic or the clinical outcome for the drug. So remember, therapeutics and pharmacology are not necessarily the same, they're related, okay? But this acute pharmacological effect study could be like just a side effect of the drug. It might not be, like I was teasing the other day talking about Rogaine and that kind of stuff. With the clinical outcome, okay, they're actually looking at the therapeutic effect of the drug. So say for instance, we had, what do you call those? Are they oral hypoglycemics? I'm just making up an example. To lower glucose, oral, for type 2 diabetes. Okay, so let's just say there was a new oral hypoglycemic agent that a company was developing, and they wanted to do a clinical outcome study. Okay, then they might be looking at the ability, comparing test drug products to compare the ability to lower glucose after an oral dose or after some dose other than the regular way that we administer insulin. And whichever, at least in theory, the idea would be, well, to lower the glucose level, it might take more than one dose. It might take several days or whatever the dose they give to get the glucose level down to a pre-diabetic or a non-diabetic type level in the bloodstream. So that would be a clinical outcome. Because they can actually measure, that's the idea behind the oral hypoglycemics, to get the glucose down to a certain level. They might have some other acute side effects, pharmacological effects, but that's not what's being measured in the clinical outcome study. We're actually looking at the therapeutic effect of the drug. Okay? And the idea, at least the thinking is, which whichever drug product is able to lower, in the case of an oral hypoglycemic agent, whichever drug product is able to lower the glucose level to the greatest extent and most rapidly would be the one that's more bioavailable. Does that make sense? Remember we said bioavailability, the extent and rate of absorption. So we're looking at oral hypoglycemics and we're looking at this therapeutic or this clinical outcome, then, you know, one of our measurements might be lowering glucose levels. And it would be easy to say, well, not so easy, and we'll talk about some of the caveats in a moment, but at least we would want to say, well, whichever one lowered the glucose level to the greatest extent and did it faster, that's the one that's more bioavailable. Can we chew on that for a moment? Does that make sense? Okay, we're actually looking at a clinical outcome. Now here's the rub. Can you think of any reason why, and this is going back to some things you talked about in pharmacology. Can you think of any reason why the drug product that lowered the glucose more and did it more rapidly, why it might be difficult to say that that's the product that's the most bioavailable? It's a pharmacologic concept I'm getting at now that you talked about in pharmacology.
If it was administered with another drug that.
No, let's just assume now we gave drug product A, it's an oral hypoglycemic agent, you know. We gave it, you know, long enough to reduce the glucose level. It might have taken 3 or 4 days or whatever, you know, we're doing multiple dosing. And then after we did a washout, you know, waited for at least 5 half lines, you know, usually it's gonna be a week or longer before the investigator will tell us that the volunteer or the patient or whoever's doing this drug study to come back and we're gonna try, you know, drug product B. Now, you know, I think you probably talked about in therapeutics and or pharmacology, these drug studies, well, you've had biostatistics too, so, you know, the drug studies are usually double-blinded. So neither the physician, whoever's giving the medication, or the patient know which one they're getting, okay? So I'm oversimplifying when I say, well, they're gonna get the first one, and then they're gonna tell them to come back and take the second one, and then, you know, then it's probably gonna be a placebo in that group also. So they come back and they get the second drug product, the second oral hypoglycemic agent, okay? And so we got data from 2 drug products now. And it looks like drug product A has lowered the glucose level to a greater extent and looked like it did it more rapidly. So now I want to conclude that drug product A is more bioavailable than drug product B. Everybody following me so far? What are some other things I need to think about though, or consider before I come to that conclusion? In other words, let me ask you another way. Why could it be that drug product A, even though apparently it worked better, why could it be for some reason other than it has a higher bioavailability? It's a pharmacologic concept I'm trying to.
Are you talking about like the metabolizing of it, like the enzymes? Or?
Okay, come on, expound. Who's talking? Because y'all got these masks. Okay, B, that's you?
Yeah.
It sounded like it was coming from back there. So. Okay, so she said something about metabolizing enzymes. Expound on it a little bit.
Okay, so you have CYPs. Certain ones are inducers, certain ones are inhibitors.
Okay, very good. So really, we're talking about pharmacogenomics and interpatient variation and that kind of stuff. So it could be that the drug product A and B, perhaps, because remember now the clinical endpoint study, the clinical outcome study, we're not looking at blood levels. We're just looking at the therapeutic effect of the drug. Okay, it could be that drug product A and B had the same bioavailability, just hypothetically. But maybe drug product A outperformed drug product B, okay? Because remember, these studies are done not just in 1 or 2 people, they're done in dozens of, sometimes hundreds of people. So it could be, as Leslie is saying, that, well, maybe the difference had to do with interpatient variability, you know, differences in metabolism of the drug, difference in the amount of enzyme or the sensitivity of the enzyme in different patients. So if one patient, let's just say hypothetically, we got 2 patients. One patient has high enzyme activity, and another one, this is a drug that's metabolized, for instance. And another patient has lower enzyme activity. Well, the drug could get into the bloodstream for both of those patients to the same extent, but probably the one that has the higher enzyme activity, let's just say the enzyme activity has to do with metabolism, is probably going to metabolize that drug faster And if that drug is being metabolized faster in one patient or one group of patients versus another group of patients, then it's probably gonna have a greater or lesser effect. If it's being metabolized faster in a group of patients than it is in another group, is it gonna have a higher effect or a diminished effect? Huh? Y'all wanna talk to me this morning? I mean, is that what Friday does to us also?
In respect.
If it's metabolized to an inactive metabolite more rapidly or more avidly in one patient versus another, what is the effect of that higher rapid metabolism gonna have on the therapeutic effect? Is it gonna be greater therapeutic effect or lower therapeutic effect? No, I'm trying to get y'all to think, and if you are thinking, then at least talk to me. Okay, so we can have, as Barrera pointed out, we can have, you know, differences in enzyme activity and stuff like that could kind of confound the results from the clinical outcome study. So when a clinical outcome study is done, the investigator has to make sure that, hey, if I see a difference in drug product A versus drug product B, same drug, just different drug products, that I got to make sure that it's due to differences in pharmacokinetics, you know, differences in the absorption or bioavailability, and it's not necessarily due to interpatient variabilities like differences you've learned in pharmacology about receptor science. It only makes sense that if one patient has more receptors for the drug, or the receptors in one patient are more sensitive to the drug, they bind the drug more tightly. Then in another patient, if it's a receptor situation, when you predict that in the patients where I have either more receptors for this oral hypoglycemic agent, or if the receptors in the patient are more sensitive, you know, bind the drug more tightly, wouldn't I, based on pharmacological principles, expect that I'll get a greater effect in the patient where I had more receptors and either receptors were more sensitive and bound the drug more tightly? So sometimes it's kind of hard to say that any difference that we see when we do a clinical outcome study that's actually due to differences in the bioavailability of the drug. There could be some other things like differences in enzyme activity or differences in receptor binder or whatever that could also lead to differences in the therapeutic or the clinical outcome. Does that make sense? So of these four methods, this is the hardest one to do, that clinical outcome study. You know, because it's going to take a long period of time. Of course, the plasma data, the urine excretion data are the shorter of the four. You know. The acute pharmacological effect, okay, it might not take that long either if we're looking at an acute effect, the side effect of the drug or whatever. But the clinical outcome study, you know, usually it's going to be a longer study, depending on what the clinical or the therapeutic endpoint is that we're looking at. But this number 4 here is the most difficult of those 4 types of studies to do, and maybe the most unreliable. Okay, so usually that type of study, a clinical endpoint study, is I have here in my notes here that a lot of times this type of study is used for like the topical administration, like acne preparations, topical administration, where the drug product doesn't have any systemic, you know, we're not dependent on the drug product to get in the bloodstream. So a lot of times this type of study is done for something like an acne preparation that's going to be used topically. Okay. Or topical antifungals. Antifungal preparations. These two uses, this is not exclusive. I'm just saying these are examples where, you know, a clinical outcome study would be more likely to be used. Okay. So if we have an acne preparation, we ain't worried about the drug getting into the bloodstream. It's just a local effect or whatever the case may be. Same thing with a topical antifungal preparation. We're not trying to get drug into the bloodstream. We're just trying to get drug, you know, into different layers of the skin or whatever to treat that preparation. So these are just 2 examples. I think I took those from the textbook where a clinical endpoint, a therapeutic outcome study might be, you know, of more utility than trying to do a plasma, you know, plasma data study, urine data study, where we're not even expecting, at least the idea is not for the agri preparation to get into the bloodstream. Now, let me say here's a caveat, because even though we, you know, for the agri preparation to work, we don't need it to get in the bloodstream. If it's a topical preparation, both of these are topical. I'm talking about the topical, but they might have some stuff you take for acne that, you know, you take orally, but I'm talking about topical preparation. But just as an aside, and I think you probably learned in the dosage form course, okay, that there are topical preparations. This is just for general knowledge, not necessarily methods of assessing bioavailability. We can put things on our skin and it can get absorbed into the bloodstream, okay? So I don't want you to think that, well, hey, in these two examples, that none of the drug reaches the bloodstream. That can actually happen, but that's not the intent, okay? What we're trying to treat clinically, it doesn't require, if it's an active preparation that we put on topically, or an antifungal topical preparation, it doesn't require any systemic absorption of the drug. Does that make sense what I'm saying? Even though some of the drug could end up in the bloodstream.
Mm-hmm.
Some of the drugs, you know, even though we put it on the skin, well, it could end up in the bloodstream. Because there's a dermal layer of skin, up under the epidermis, I've forgotten all the different layers, but I think in the dermal layer, that's where you have capillaries.
So is that why it's
And capillaries can
unreliable?
absorb the drug. So if it reaches the dermal layer, it's possible that even if it's a topical preparation, some of it can end up in the bloodstream. Yes, ma'am?
Is that why it's unreliable?
Say that again?
So why is that method unreliable again? Is that why?
No, it's not as reliable as the first three. Certainly not going to even come close to the first two, because like I said, that you have interpatient variability. So the interpatient variability might cause differences in the effect, clinical outcome effect, that don't have nothing to do with bioavailability.
Mm-hmm.
So I'm saying you can have two products with the same exact bioavailability as determined by blood concentrations. But one product could have a higher clinical outcome effect than the other one, because as you pointed out, like we said, it could be differences in binding ability, you know, interpatient variation. There could be differences in the number of receptors in one patient versus others, even though it's the same amount of drug in the bloodstream. So I think I did use the term unreliable, and maybe I shouldn't say unreliable, and just leave it at the clinical outcome study of all of these four, okay, is the most challenging. Let's just put it that way. You know, a lot more work has to go into trying to assess bioavailability by clinical outcome study. That's why, you know, a lot of times it's done just for the topical preparation. But there are some times when a clinical outcome study, I might need that drug to actually get into the bloodstream. Okay? But in the case of these two situations, I don't need the drug to get to the bloodstream at all. So it makes it a little bit easier to assess the study. You follow what I'm saying? Because now with these, you know, I just need drug to get into the skin, into that lesion, or you know, whatever the case may be. And now I'm going to say, well, hey, whichever one of them clears up that acne faster is more bioavailable. But bioavailable in the sense that not that it's getting into the bloodstream, but bioavailable that, yeah, it's getting into that lesion or that skin more rapidly than the other. Okay, so that's all I wanted to say about that. And then the last thing I want to talk about under bioavailability and bioequivalence is just say a little bit about the design. Design and evaluation. Bioequivalence study. So, when these studies are being set up, usually the investigators, you've probably seen ads that, especially within this pandemic environment, there are a host of studies going on now to test COVID treatments and stuff like that. Okay, so usually the investigators, they're going to advertise for participants in the study. Usually, the idea behind doing a bioequivalent study is to determine whether different drug products are bioequivalent. And I gave you the definition of what bioequivalence means, okay? So we're trying to determine whether products are bioequivalent or not. Usually the participants in the study, they're usually going to be volunteers. Usually in a bioequivalent study, these are normal, healthy human subjects. Now there could be some exclusions. I mean, the investigator might say, we want, males and or females at a certain age range. We want non-smokers in our study, or whatever. So they can set some selection criteria, but generally speaking, in these bioequivalent studies, these are going to be normal, healthy volunteers. So if it's that oral hypoglycemic agent I was talking about a few minutes ago, okay, the study subjects are not going to usually be to determine bioequivalence of the products. Okay. Remember now, we're not trying to measure therapeutic effect, but the conclusion is that two products, if they are bioequivalent, then they're going to have similar therapeutic effects. But in a bioequivalent study, we're not measuring therapeutic effects. We're actually measuring blood concentration or urine concentration of the drug, whatever, to determine whether or not they're bioequivalent, whether they have similar areas under the curve and that kind of stuff, relative bioavailability and absolute bioavailability. So these are usually going to be normal, healthy human volunteers. They're not going to generally have the disease state or the pathophysiological condition for which that drug product is made. So if I'm looking to do a bioequivalent study with these oral hypoglycemic agents, the subjects are not going to have diabetes. Does that make sense what I'm saying?
Mm-hmm.
Shouldn't they check to see if it works?
No, remember, we're not trying to measure therapeutic effect here. We're just saying that if they are bioequivalent, we can assume that they are going to have similar therapeutic effects. With the idea in a bioequivalent study, we're not looking at, therapeutic effects. We're trying to see if they're bioequivalent or not. Okay? So there's a key word up here. Okay. So we're going to be looking at, blood concentrations or urine concentrations or whatever the case may be. So usually these subjects, like I say, they're not going to have any. Usually they're not going to have the disease state for which the drug product is made. There's going to be a reference standard. Okay. We're going to have a reference standard. I like to think of a bioequivalent study. I like to think of, and your book doesn't explain it this way, but to make it simple for us, basically in a bioequivalent study, we're talking about relative bioavailability, more so than absolute bioavailability. So just generally speaking, this ain't gospel, but generally speaking, if the test product has 100% relative bioavailability compared to the reference standard, then we can say that they are bioequivalent. In other words, if the relative bioavailability is 100%, that means that whatever we're testing was absorbed to the same extent as the reference standard, right? So if that value is 100%, I don't want to say they're bioequivalent because we need to look at the rate also. The relative bioavailability just tells us, that the area under the curve, we assume we gave the same dose. For the test product, let's just assume it's the same dose. For the area under the curve from 0 to infinity for the reference, that they're the same. If that value is equal to 1, or percentage-wise 100%, then so that's one criteria. That just tells us they absorb to the same extent. So we still would need to look at the rate also, the plasma concentration time curve or urinary excretion, to see if the rates are similar, the same. Okay. So what I'm trying to do is make the distinction here between relative bioavailability and absolute bioavailability. So with our bioequivalent study, okay, we're going to be looking at relative bioavailability more than absolute bioavailability. Does that make sense what I'm saying?
Okay.
You know, so with relative bioavailability, if this is an oral formulation, the test formulation, then the reference is gonna be an oral formulation also. But with absolute bioavailability, you know, that's an IV dose, all that, okay? So that's the distinction I'm trying to make here, okay? So this is just one criteria, you know, for the drug product to be, bioequivalent, and that would mean that the relative bioavailability or whatever, but all of the subjects in the study, in the drug study, all of them are gonna get the reference standard, and all of, you know, they might not know that they're getting it at a certain time, but all of them are gonna get the reference standard, all of them are gonna get the test products. So it could be more than one test product being tested. You know, like in our laboratory exercise, you know, we had an oral capsule, an oral solution, and an oral tablet, you know. Well, in this study, from your textbook, from the laboratory, okay, well, we established that the oral solution could be the reference standard. So now we're gonna test the oral tablet and the oral capsule. So we don't have to just have one test product. If we had 2 or more test products, all of the subjects are gonna get the test product, but just at different times, not all at the same time. And all of the subjects are gonna get the reference product as well. Okay, so we'll have pharmacokinetic data on all of the subjects that participate in the study. We'll have pharmacokinetic data, plasma concentration time data for all of the test products and the reference standard. There's only one reference standard that's gonna be used, okay?
And are you saying if you test, the one you're testing over the reference equals to 1, that's how you know they're bioequivalent?
Yeah, that's what, well, I changed that. I said that's one criteria, you know, this is just one criteria. We also need to look at the absorption rate.
Okay, okay.
So remember, we talked about this the other day in class, absorption rate, or the, you know, Ka value, or Tmax value, okay? We still need to look at how the test compares to the reference, you know. So for instance, hypothetically, okay, I'll go back since we're here. So let's just say on average, we're looking at concentration time, and we got 2 test products. We got, I'm calling X and Y instead of, because I don't want, you know, we got 2, I'll call them test product A and test product B. So we got one test product like this, we call this test product A. Test product A. And we got another test product that looks like this. I don't want to do a drug like that, that's not right. What's wrong with what I'm trying to do for B already, based on what we talked about before? What's wrong with that curve?
The KL's not the same.
Right, I want to draw it so the terminal phase, the post-absorption phase, so it's parallel. Very good, okay. So I don't want to draw it right like that. Let's try it again. Let's see if I can go do something like this. This is similar to what we had in the laboratory, so I'll say test product B. Test product B. So obviously test product A is being absorbed faster, okay? So we have to look at, you know, let's say that the area under the curve for A is equal to area under the curve for B. We had examples like this in the table 1622 in the textbook. So we could say they have similar rates of absorption. In other words, this ratio right here is going to be 100%. It's going to equal to 1. But we couldn't say yet that they are bioequivalent until we look at a plasma concentration time curve or urinary excretion or something to see how the Tmax value, which is indicative of the Ka value, assuming that KL is the same for both of them. So in terms of our hard definition of bioequivalence, these 2 products would not be bioequivalent because they have different rates of absorption, even though the extent of absorption would be equal. You know, the relative bioavailability is 1, so they, you know, absorb to the same extent. But you know, unless this slower rate of absorption from test product B, unless that's by design, like we talked about in class, or you know, extended release or sustained release or something like that, and that difference for test product B in the rates doesn't affect the clinical, because if the drug manufacturer decides they want to make a sustained release formulation, but it has a significant adverse effect on the clinical response, then there's no way these would be considered bioequivalent. Because, you know, as a practitioner, you know, pharmacist or a physician, whatever the case may be, you know, it's just generally assumed that if 2 drug products are bioequivalent, then we can make a substitution if necessary, okay? The patient was on test product A, okay?
This is more like what bioequivalent products would look like, okay? There's no doubt about it, okay? So that those funny looking lines, those funny looking lines would be, I'm just gonna call it product X. And the solid line would be product Y. I'm just making up stuff as it goes. But now, in this case, we talk about something that ain't about a doubt, it's bioequivalent, because they have, the funny little lines is one product, okay? And the solid line is a separate product, so they have pretty much the same Tmax value, which means they're gonna have the same Ka value, absorption rate, and the areas of the curve are the same. There's no doubt about that, those are bioequivalent. So let's just say that the patient was on the one that gave the dash line, but that's an expensive drug. That's an expensive drug. And the government then negotiated with Medicare and stuff like that and say, Medicare said, we not paying for that drug anymore, okay? We're not gonna pay for this one no more, okay? The one, with those lines, it's too expensive. So the physician might ask you, the pharmacist, do you have something that, I can substitute that's cheaper? Tell them that, because they're bioequivalent. So the idea behind the bioequivalent drug product is that, in general, it's gonna have the same therapeutic effect. So when I make a substitution, I'm gonna give that patient a drug product with a lower cost, we're gonna have the same therapeutic effect. Now let's just say the relative bioavailability for the drug product was, the solid line was what the patient was on, but now we got another drug product that looks like this. Okay. Another product looks like that. You can see that this is a third product now, this global. But would it have a relative bioavailability of 100% compared to those first two? Would it have a relative bioavailability of 100%? Let's call these two A and B, A and B. Let's call this one down here C. I'm making up stuff as I go, so if you have questions, please. Let's say this is a third test product. Would the relative bioavailability of this C be less than 100% or greater than 100% compared to A and B?
The area under the curve is different.
I know, so I'm asking you, how would the relative bioavailability, would it be less than 1 or greater than 1 or what? For C.
It should be less than 1.
If I'm comparing C and I'm using A and B as your reference standard, let's
It
make
should be
it
less
simple.
than 1.
Let's say we use A and B as your reference standard, A or B as your reference standard. The relative bioavailability is gonna be less than 1, right? So let's just say that the relative bioavailability of C compared to A or B is 50%. If I wanted to make a generic or therapeutic substitution with drug product C, let's just say that the area under the curve for C, area under the curve for drug product C was equal to only 50% of the area under the curve for drug product A. Area under the curve for C is equal to 50%, 0.5 of drug product A, which means it would be 0.5 of drug product B as well, right? If I wanted to substitute drug product C, I would have to get twice as much to get the same concentration. That's what I'm trying to get you to see.
Okay.
If I want to it might be that, the patient was only taking, 100 milligrams every 6 hours. I'm just making for A and B. I just want you to see why we're doing bioavailability and bioavailability. The patient was taking 100 milligrams every 6 hours. Okay. A is too expensive, let's say B is too expensive too. But I got that same drug from a different company for drug product C. But when I do my literature search, I find that the relative bioavailability of C compared to A or B is only 50%. So where they were taking one tablet every 6 hours here, okay, they might have to take 2 tablets every 6 hours here to get the same concentration. But that 2 tablets might be, for C, might be cheaper than 1 tablet for A and B. That's what I'm trying to get you to see. That's why this is important. Because you will be called upon sometime to, recommend a substitution or the physician might change the drug product to something. You might recognize from your bioavailability and bioequivalence knowledge that, doc, you know, you might call them back or write them and say, no, you know, you need to increase the dose, you know, if you don't make that substitution, because these products are not bioequivalent. You know, so if drug product C was only absorbed half the extent of drug product A and B, and I want to switch to C, then that means I have to double the dose of drug product C in order to get the same concentrations that I was getting when I had the patient on drug product A or B. That's why this is important. You know, again, you know, we normally assume that if two drug products are bioequivalent, that they're also therapeutically equivalent, that they're going to give the same therapeutic effect. That's what's going on. Does that make sense now? You know, so the drug companies, you know, when they're doing their bioequivalency studies, you know, let's say we'll go back to the oral hypoglycemia, okay? So they isolate that drug as a pure drug. So one thing they want to find out from a pharmacokinetic point of view is the absolute bioavailability of that drug. The absence of this pure oral hypoglycemic agent, okay? So I want to find the bioavailability of the drug, okay? Let's say the bioavailability, this is a sidebar from the bioequivalence study. So let's just say the absolute bioavailability of the pure drug is equal to 100% of some pure drug. Everybody with me? But you are not going to be dispensing a pure drug, and the pharmaceutical manufacturer is not going to be packaging the pure drug, right? They're going to put it in a dosage form. Everybody follow what I'm saying? So first of all, we need to do some absolute bioavailability studies of the pure drug. But now I take that pure drug and I put it in a capsule. So that dot represents the pure drug in the capsule. Now, if I do absolute bioavailabilities on that pure drug in the capsule with the pure drug in it. Pure drug. Or tablet. I don't know how to make the tablet different. I just don't laugh. I'm very sensitive. Okay? I'm very sensitive. I'm in therapy. Do not be laughing. Tablet with pure drug. I'm doing this because I'm really trying to connect the dots between some things we learned in dosage forms, and kinetics, and other things. So it could be a tablet, it could be a solution or suspension or whatever. But the bottom line is, these are two different formulations here. They might not be 100% bioavailable. Even though the pure drug was 100%, now when I put it in that dosage form, it might not be 100%. Because now, you remember we got GI physiology and stuff, so that tablet's got to dissolve, got to disintegrate, and stuff like that. But stuff is moving the whole while. Same thing with the capsule. So that's what I'm trying to get you to see. When we talk about absolute bioavailability, even if the drug is 100% bioavailable, once we put it, in a dosage formulation, and we do a similar study to test bioavailability, it might not be 100% anymore. It might not be 100%. It could still be 100%. I'm not saying it's not going to be, but it's not necessarily going to, the absolute bioavailability of that drug product is not necessarily the same as the absolute bioavailability of the drug in that product. The pharmaceutical manufacturing companies have to look at both of them. So that's why that leads us back to our bioequivalence study, because when we look at the bioequivalence study, we're looking at drug products. We're not usually testing the pure drug in a bioequivalence study. We're looking at the actual drug products, the actual formulation of the drug. Nobody cares if the pure drugs are bioequivalent or not, because that's not what the patient's going to be taking anyway. They're going to be taking a drug product, a dosage formulation of the drug.
So in terms of that graph, which one would be better in terms of capsule and tablet?
In terms of what? You talking about this? All I can say is that, generally speaking, a solution or suspension is going to be absorbed faster and to the greatest extent. And these are just guidelines, okay? Generally speaking, a conventional capsule generally speaking, will be absorbed faster than a tablet, because the capsule, all it has to do, I'm talking about a regular capsule.
Mhm.
All it has to do, well, yeah, the capsule is already disintegrated inside the capsule. It just, that gel just needs to dissolve, and then bang, it's gonna release all of those fine granule powders or whatever. Whereas a tablet has to break down first until, remember we talked about the disintegration, you probably talked about that in dosage form too. So it has to break down into big particles, and then it has to disintegrate into even smaller particles. And then after the smaller particles occur in the GI fluids, then you start getting the dissolution process. Okay. So generally speaking, a capsule will be absorbed faster than a tablet. Generally speaking, you can have a situation where a capsule in a solution or a tablet in a solution are absorbed pretty much the same rate. In other words, physiologically, from a statistical point of view, you can't tell the difference between the two. That's why, you know, in your drug studies and stuff like that, when you read in therapeutics, and they tell you to go read an article or whatever the case may be, and an investigator concludes, okay, that, you know, they test these drugs and they say, you know, that there is a statistically significant difference in the therapeutic effect of this drug, or there is a statistically significant difference in whatever. That statistically significant difference does not always translate into something that's therapeutically significant. So in terms of absorption, even though the solution might be absorbed faster and to a greater extent, kinetically speaking, you follow what I'm saying? It might not have any therapeutic or clinical significance. Does that make sense what I'm saying? Just because something, just because something is absorbed faster, whatever the case
Doesn't
is.
mean it has a greater effect.
Yeah, exactly right. It might not have clinical significance. It might not have clinical significance. It might have pharmacokinetic significance. You know, you do your t-test, your p-value and all that kind of stuff like you learn about in statistics, okay? And you can say, okay, well, the difference is statistically significant. But then in terms of clinical outcomes, it may or may not be clinically significant. That's what I'm trying to get you to see. It took me a long time, you know, because a lot of times you're going to read studies and they'll tell you that, yeah, there's a statistically significant difference, but it's not of any therapeutic significance. Okay. That's the difference. Okay, so the reference standard, you know, I've already told you a couple of days ago, usually we want the reference standard to be a solution or suspension if it's available. For some drug products, we don't have a solution or a suspension. Remember now, we're talking about basically about relative bioavailability studies, because we already know with an absolute bioavailability, the reference standard is going to be IV dose. Okay. So for the bioequivalent study, you know, we would like to have a solution or a suspension, you know. But if we don't have that, then we have to choose some other dosage formulation as the reference standard. And in any event, whether it's a solution or suspension, or whether the reference standard is a tablet or a capsule, whatever, we want the reference standard to be a drug product that's widely recognized and used within the medical profession. We don't, in other words, we don't want our reference standard to be something that's obscure, nobody's ever heard of. Because if we find that the relative bioavailability is 100% for one of these test products, and nobody ain't never heard of the reference standard, don't know what the hell that is, that 100% ain't gonna mean diddly squat, is it? You know, we're comparing, you know, we have these several aspirin formulations, okay, that we want to test. But the reference standard is Ikemi's, is that right? Autumn, she made something in the laboratory, so we use her as the reference standard. And then we publish it. Say, okay, well, these test products have a relative bioavailability of 100%, so they're bioequivalent. The reader's gonna say, what the hell is Ikemi? We ain't never heard of that, so that don't, you know, that 100% doesn't mean a whole bunch, because the standard that we compare them to, nobody's ever heard of, nobody's ever used it before. Does that make sense what I'm saying? So we want the reference standard to be a product that's, you know, that's known and widely used by the medical profession.
So what would be our option?
Say what?
So what would be our option?
I'm just, what other than Ikemi?
No.
Please.
No, other than like the solution you said.
I'm saying that if we don't have a solution or suspension, then we can use a tablet, a capsule, or another dosage form on the market.
Okay, so
It
you
is
can
a go.
research it.
Yeah,
Okay.
that has a long history of use and acceptance within the medical community. I'm just saying that preferably, we will want to, we got a choice between a solution and a capsule as a reference standard. In a bioavailability study, we're gonna use the solution, that's what I'm saying,
Okay.
if we have that choice. If we have a choice between a suspension and a capsule as the reference standard, we're gonna choose suspension. Does that make sense?
Yeah.
That's what, okay. If we got a choice between a suspension and a solution,
Solution.
generally speaking, but they could be the same. But then after we could go to the literature, do some research and see, okay, what's the absolute bioavailability of the solution? What's the absolute bioavailability of suspension? Notice I'm not saying relative bioavailability. I'm trying to choose between the suspension and solution. I would want to choose the one that's more bioavailable. Does that make sense here? If they have the same bioavailability, I'm talking about absolute now. So that means that I need to go to the literature and see, okay, this suspension, somebody's done an absolute bioavailability study on that suspension where we compare it to an IV dose. Somebody's done an absolute bioavailability study on that solution where that solution was compared, the oral solution compared to an IV dose. Everybody follow what I'm saying? So whichever one of them has the higher absolute bioavailability, then I would preferably use that as the reference standard in my relative bioavailability study. Am I making sense? Is it coming together?
Yes.
Okay, very good. Okay, I think, okay, I said that they're usually, okay, so I've already said that these are usually normal, healthy human volunteers. Oh, the subjects in the study, the participants, they're usually fasted overnight prior to the study. So the investigator's gonna tell the participant, they get paid, by the way, okay, handsomely, okay? But they're gonna tell the participant to not eat anything overnight, usually it's overnight. So they tell you to come in tomorrow morning. They're gonna tell you not to eat anything tonight. Generally speaking, okay? Why is that?
You don't want the food to disrupt your study.
Okay, we don't want to, thank you, obviously, we don't want the food to disrupt our study. Right, because we've already talked about the fact the food can play around with gastric emptying time and all that kind of can affect absorption. So most drugs are gonna be more bioavailable on an empty stomach. The reason we counsel patients to take food with a lot of drugs is to avoid the GI irritation or whatever, okay? But in a bioequivalent study, the patient might have to be inconvenienced somewhat so we can get the actual optimal value for whatever the bioavailability of the drug. So usually they're gonna be fasted prior to taking the different formulations of the drug. And then after they take the formulation, usually from about 2 to 4 hours after they take the drug, the investigator is gonna tell them to not eat also. But that makes sense, right? In other words, we don't want them to take the formulation now and then run out to Wendy's, right after they leave, because that could also affect the absorption from the gastrointestinal tract, okay? So usually for a period of about 2 to 4 hours. I have here my notes that no other medication is normally, take this with a grain of salt, that no other medication is normally given to the patient for 1 week prior to the study. The investigators, they set the inclusion criteria, so that's just a general guideline. If the patient is on medication that the investigator think might interfere, with the study, then that patient probably just would not be included in the study. So, but if there's an option where the patients cannot take medication, and when I say medication, I'm talking about medications for other diseases. We've already said that in these studies, usually these are going to be normal, healthy volunteers. Healthy meaning that they don't have the disease state or the pathophysiological condition for which that drug product is designed. Okay. A crossover design. What's a crossover design? You remember from biostatistics? What's a crossover study?
In the beginning,
They use this.
say for instance, group A is taking acetaminophen, and group B is taking like aspirin, and then over a period of time, once they'll stop and they'll switch the drug.
Well, in this case, not. you were halfway right, but in this case, remember, you just said two different drugs, you said acetaminophen and
Yeah,
naphthalene,
they
we
use
only
the
got
same
one
one.
drug, just different drug products.
Oh,
Yeah,
okay.
So
same
the
drug.
crossover, in the crossover study, you know, we got a host of different volunteers or whatever the case may be. So crossover kinda means that, like I said earlier, that all of the patients, you talked about different drugs.
Mhm.
So all of the patients are gonna get the drug, the different drug products.
Oh, so
Same,
it's
yeah.
with the product.
Yeah.
and then
Yeah,
after
so,
a period
so,
of
so
time,
crossover means that, you know, if you and me, and right here, that, let's say we were testing drug product A, okay? All three of y'all are gonna get drug product A, but not necessarily at the same time,
same
whatever,
time.
you know? If we're testing drug product A and B, you know, we might give drug product B here, you might get A or whatever. But before the study's concluded, everybody's gonna get drug product A and B, okay? That's what it means. And it's usually randomized, so, you know, these different, subjects, they're not all getting A at the same time, and then all getting B at the same time or whatever. So it's usually a random, crossover type study, okay? And then usually we're gonna have a control, you know, some type of, placebo. Well, I shouldn't even say that, because we're not looking at therapeutic effect. With a therapeutic study, we would have a placebo involved, okay? So it's gonna be a crossover study, and it's gonna be random. Like I said, random just means that I'm not gonna give all of the test subjects drug product A, and then a week later give them all drug product B, and then, no, we want to randomize that. And then we also wanna allow enough period between dosing,
A
a
washout.
washout period, okay? So if you take a drug product today, depending on the half-life of that drug, the investigator ain't gonna say come back five half-lives later. They might say, you know, that drug has a half-life of 3 hours, but only 15 hours, 5 times 3, but they might say come back next week. Cause they know you got a life too, you know, you don't wanna be taking, you know, back to back to back or whatever. But you do have to allow an elimination, period or washout period between doses, so that, you know, when we get ready to do our plasma concentration time curves, we can know, yeah, that whatever we see is from that last dose that we gave. Okay, but remember, we're not comparing different drugs. All of these concentrations here are from the same drug, okay? So we have to make sure that every time we give a dose, as the audience said, that we starting fresh. So whatever we see in the plasma or the urine is from the dose that we just gave. Okay, I think that's all I wanted to cover here. Questions? Questions? I'm so used to seeing Dr. Poon now.
Oh, we don't have class today.
That's right. You all usually have on Friday as well.
Oh, no, we do.
No, I'm saying right after mine on Friday? Oh, I thought you all didn't have,
Just today,
Just today, we have, pretty much all the classes were canceled today. We were trying to reach you, but there was no way to.
I'm so